I'm going to, instead of focusing on just a new ARV, I just give you a whole picture of evolution of the HIV care, and some have been in-depth touched on in terms of treatment of adolescents. But I think I'd like to, emphasize of us again that the figure is still running, although we have been facing pandemics, but HIV issues still remain. And then you can see that globally, people living with HIV still up to 40 million. And before we have such a great treatment, in the early era of HIV epidemics, is half of them, 36 million, died totally in the past early stage of the epidemics. And more than 500,000 die each year, and 1.5 million new infection. In Thailand, right now, we still have more than 6,000 new cases, and half is adolescent or younger age group. Now, if we look back in the 4 decades, since 1981, you can see that at the beginning, before having ARV, people just dying, when they have immunocompromised. And when we start to have the first class is in our nucleoside liver transcriptase, and it's just only one class. You have one drug, monotherapy, 2 drugs. Survival is improving, but it's short. And in the mid 90s, we have 3 drugs. So we have two classes. One is the NRTI and the boosted PI. So the survival is totally different, and the people can reach undetectable. But the pill burden and toxicity is a problem. Until, early 2020 and early 2012, and then up to now, you can see that we have a lot of knowledge and availability of treatment option. We learned that we should treat early. We learned that we have a better option. And just recently, in the last few years, we have a long-acting treatment option, and we still questing for cure, and you have heard a very nice talk from Professor Kaliher. And what we have learned is that the treatment has normalized survival very significantly, and then you can see that normalized means even from the Thai National AIDS Program analysis, people, if they got HIV infection at 12 years old, so you can survive, add up another 60 years old. So what the current treatment option that we have, you can see that right now we have the key classes is NRTI, integrase inhibitor, protease inhibitor, and NNRTI. Now, the principle of triple drug therapy or HART in the past is you combine backbone, what we call the 2 NOCs, with either one of the class, and the most highly recommended, I'm going to get into it in a few minutes, is that the integrase inhibitor, or you can go with the protease inhibitor or NNRTI. Now, the tremendous difference is back in 90 and up to now. So it's really a difference in terms of number of pill and the size of the pill. What the reason of that the pill size is getting smaller? Because we get a higher potency of the ARV. You look at this, TDF, you start with, the recommended dose is 300 milligrams, and you shift to TAF, it's only 25, so it's about 12-fold lower. And then for F valence, 600 down to either DTG big or lipulin, so it's more than 12-fold lower. So the pill size is getting really smaller. And that's good for everyone, not only adolescents, for everyone. You prefer to take smaller pill. Now, why integrase inhibitor, particular DTG-based regimen, has been, highly recommended from all the guidelines worldwide? Because all the randomized control trial, phase 3, as you can see, you can name it, Spring 2, Flamingo, Area, and others. So you see that DTG superior to other classes, superior to NNRTI, equivalent, superior to darunavir, superior to etasanavir boosted, but non-inferior to the same class of integrase inhibitor. And the other favorable characteristic or profile of integrase inhibitor is the no mu restriction. That, of course, including one of the NNRTI, the Wyverine as well. So, but with equivalent, you have to make sure that if someone that have CNS side effect, you prefer to have them to take during the empty stomach. The other profile that in favor to integrate particular DTG and BIGs is the resistant barrier, genetic resistant barriers, much better than other, NNRTI and better than ralticavir in the same class. So that's why if you look at the US DSS guideline, the IS guideline, European guideline, WHO guideline, and many national guidelines, you look at integrase inhibitor, dolutegravir. In the high income country, of course, they prefer bictegravir because of what? Bictegravir combined with TAF, you have a smaller pill, right? So that's the point. And in the single tablet regimen, in the high income country, they have only a bacavir 3TC, so that the pill is bigger, and also have to test the HRAB 5701. So that the reason that people favor that. The other interesting information is that this triple therapy, either TLD or TAF FTC DTG, is a lower cost because of the we don't have a patent issue in this type of combination. So you look at the South African continent, in the African continent, you see that the whole year is only $75. In Thailand, it's about 20 to 35 per month. So this is the Thai guideline. So we are, like many other Asian countries, that we transition from equivalent to DTG, and hopefully by this year or the end of the year, we can transit to DTG TAF FTC. Ajahn Kunkanya have touched on a bit on the pregnancy safety. So the US guideline, based on the information of the Botswana cohort, that the longer follow-up, there's no significant difference of that the neural tubes related to DTG issue. So they recommend the same as other most individual first-line regimen to go for DTG. But I think it's a more conservative guideline is the British HIV Association guideline. You see that if you given DTG in the first trimester of pregnancy, less than 12 weeks, it should be recommended to take folic acid 5 milligram daily. That's the recommendation. Or you might defer, if it's a naive case, to start a DTG for at least 6 weeks. The other, although it's rare, but I think it really can be seen in your clinics. If you given a DTG regimen in an individual having hepatitis C virus co-infection, you might see a high increase of liver enzymes and even have a symptom of acute hepatitis. So it's very clear that you have to check hepatitis C in the high-risk group as well. Now, the question is, we are talking about rapid ART implementation. Can we start right away with DTG-based triple regimen, or even some setting with the dual regimen? It really depends on the setting that you are in your community or your country or your regions. That what about the baseline drug-resistant prevalence in your setting? If you have a low in general, it's less than 5 or 10% of NNRTI drug resistant or integrase drug resistant, and then that should be fine to start with that. Or even you have, I'm going to share some of this data in the next slide, that even you have a high prevalence of NNRTI and some of the NRTI, but low prevalence of integrase inhibitor, then DTG-based regimen still can be used as a rapid ART. Unlike some high-income country that patient has been experiencing a lot more with integrase inhibitor, then the baseline drug resistant testing had to be done. Or start with the boosted PI if that may be safer. And this is the good data from this study of 380, 4030. You look at the good news is that in this study, using either bitricovir-based regimen with TAF or DTG-based regimen with TAF, so the sample size up to 290. And you can see that regardless of the baseline of NRTI drug resistant, so it can be TDF resistant, K69, K65R, or even with more than 3 times mutation, or is a 3TC M184V or I mutation. You see that the pattern of viral suppression rate is very comparable. So it means that the high prevalence of NRTI drug resistant alone is not a concern. Of course, as I said, that if you're in the setting that long-acting CAP has been used for PrEP, and the integrase inhibitor regimen has been used for quite some time in that high-income country, so it's highly recommended to do drug resistant testing at the baseline before the rapid ART to start. Now, what the current trend and the future trend of HIV care in terms of antiretroviral therapy? So I think there's two trends. You have heard quite significant in adolescents as well, that the first is try to reduce the number of class, so to 2 drugs, from 3 to 2 drugs, so to triple therapy to dual therapy. The second thing is to reduce the dose frequency, so from daily to monthly to bi-monthly to 6 monthly or be to yearly. Now, let me remind all of us that when we're talking about monotherapy, dual therapy, in the past, early decade of HIV era, is totally different with the current dual therapy. In the past, we have nucleoside monotherapy, so the viral load rebound very quickly within 24 weeks. Dual therapy also rebound a bit slower, but at the end is totally resistant to the virus of those 2 drugs. With 3 drugs, in the early or the late 90s, it still looked pretty good, but with a high pill burden and quite a significant toxicity. But the past 2 drugs therapy regimen and the current 2 drugs is completely different. If you look at the recent data of dual therapy, DTG-based, DTG plus 3TC, DTG plus lepivaline, and long-acting cabotegravir with lepivaline, and recently the trial on lenacapavir and islatravir. So it's clearly that it's more significant and rapid drop of the viral load, more than 2.5 log or up to 3 log, and it's a durable sustained viral suppression. Now let me touch on a bit on the dual therapy. So in this region, again, is clearly is a different accessibility between high income and the low middle income countries. So DTG-3TC as a single tablet regimen, Dovato is not available in most low middle income countries. So if we want to go with this, we have to do a separate pill. And this is recommend can be both for first line and switch option. For DTG-RPV, as a single tablet, still again, Juluca is not, a single tablet regimen is not available in low middle income. So in the practice, so we just go with 2 pills instead of 1 pill. Long-acting cabotegravir equivalent injectable is not available in low middle income. So we hope that we can get access to that option soon. And you have seen this slide, the same slide by Jan Sukanya, that this is the real-world effectiveness of the DTG-3TC. So in the setting that people have problem with kidney toxicity from DTF, tenofovir, but cannot get access to TAF, and that will be one of the good options to go if the patient is not resistant to 3TC. There's quite a number of practical considerations when you select dual therapy. So DTG-3TC, DTG-lepivalin versus the TAF-based triple therapy. You see that hepatitis B co-infection need to make sure that you screen that. And if they do have co-infection with hepatitis B, make sure that you put them on active anti-HBV treatment. And the other can be reviewed later on. So now, how about the dual injectable drugs with cabotegravir equivalent? So the initial approval by the FDA is a monthly. That is early 2021, and for the every 2 months or 2 monthly is February, early in this, last year, February 2020. There's a lead-in, but the data also showing that you might not need oral lead-in for at least 1 month, and the dose with every 2 months will be higher than the dose with 1 month. The challenge is really, although the good thing for the patient is they don't need to come into, they don't need to take the pill every day, but one, make sure that the frequency to see the doctor in the clinic for injection is that need to be accessed as well, whether that is feasible for that individual. The general guidance to use this long-acting dual therapy, I just go to the side of contraindication. The contraindication, if any of those individuals have integrase inhibitor and NRTI resistant, except K103N, that is not eligible to take this dual injectable therapy. History of prior virological failure and co-infection with hepatitis B. And make sure that he or she agree to make frequent clinic visit. Now, what about the new class or first in class of the new drugs? There's 2 classes. One has been recently approved. The other one is still under the clinical development. So the first in class is the capsid inhibitor, lenacapavir. The other is we can call it's a new class or subclass of NRTI. So it's the NRTTI, elastopavir. Now, I think as you heard from one of the case study of Ajahn Kunkanya about multi-class drug resistance, So what the capsid inhibitor lenacapavir can offer as a first-in-class is that it inhibits a different target. So you're talking about liver transcriptase, protease, integrase, but this is a capsid, inhibit capsid function of HIV-1. So it can both inhibit replication state of both the early and late state of the life cycle. And because of different target of the HIV life cycle, so it be able to against all the viral mutation associated with the other new old classes of ARV. And most interestingly, it can be subcutaneously administration up to every 6 months or orally by weekly. The side effect is a local site injection. Now, let me give you a focus on this randomized small trial. It's just only 36 individuals randomized. It's a multi-class failing patients and have two or less than 2 fully active agents from the 4 main classes. And randomized into 2-to-1 ratio into taking oral lenacapavir and then for 2 weeks, and then go with the subcutaneous lenacapavir every 6 months up to a year of follow-up with the optimized backbone regimens compared with the control. So these are the results. So the results. The primary endpoint is week 26. You see that the response in blue is below 50 copy, in red is below 200 copy of cutoff. You see that this sustainable up to week 52, and you see that it's up to 83 below 50 copy and 86 below 200 copy per ml of plasma HIV RNA. Interestingly, again, I think it's no exceptional. Any new class coming, you need a backbone. You need at least, ideally, you need 2 active backbone. You see that without any active backbone, it's less than 70% viral suppression rate compared to 94% if you have 2 active drug backbone. And what the cause of drug resistance against lenacapavir? And they have found 8 cases. 4 of them didn't have active drug in the backbone. So it's very clear, it's just monotherapy. The other 4 failure because of inadequate adherence to the backbone. So it means, again, it's monotherapy. So that's need to be taken into the account. And this data has been recently published in New England Journal and approved by both the EMA first in August last year, and then by the US FDA a month ago. Now, let's touch on a bit on ilustravir. As I said, I would prefer to call it a subclass of NRTI, but the mechanism is not exactly the same with ACT, 2TC, and others. So it's a nucleoside liver transcriptase translocation inhibition. We have heard that by the end of 2021, in December, FDA have requested Merck to put all the clinical trial on hold. The main reason is because there's significant drop of total lymphocytes, not only CD4, but all these lymphocytes, CD8, CD4, and NK cell and other. And one of the reasons is very likely this is dose dependent. Now, what the status update of ilustravir? Just a few months ago, after the consultation with FDA, so Merck able to to initiate another couple of trial or resume some of the trial, focusing on low dose mainly. So the monthly oral high dose islatravir development for PrEP has been discontinued. And interestingly, there are two dual therapy trials. One is the phase 3. It's an oral daily with low dose islatravir versus doravirine for people living with HIV. And the phase 2 is oral weekly with low dose islatravir and lenacapavir. Interestingly, when I check what the low dose means, the high dose that has been discontinued is 120 milligram monthly, very, very high dose, and down to 0.25 milligram daily. So the pill will be even smaller, tenfold smaller with the compared with others. So what the remaining major challenge after we have all the wonderful progress in the treatment evolution and development so far, is still a problem of access, equity to access. Everyone loves to have, 2 injections a year, but the cost will be a problem. So how are we going to make it happening? Even in some country in this region, when we have a regional meeting, we have seen that DTG-based regimen transition also are not easy yet. So I think our job is how to make it more accessible it has to be. And the other challenge that has been touched on in some of the talk in this symposium is that how to care our, Ajahn Kunkanya talked about from kids, little kid to a younger adult, and now from adult to elder people. And it's more complicated as well in terms of comorbidity, multimorbidity, polypharmacy, geriatric syndrome, and psychological issue support. So I think ending it is a very challenging target, and that means by 2030 is another 7 years to go. The good news is that we have all the tools right now. So we have the best and very friendly and less toxic and low cost treatment regimen that clearly can increase survival to normal life expectation. And we know that how to reduce new cases by treat early. So identify people early and put them on treatment early. Same day or rapid ART is work, PrEP work. But it's just how to make it work. And Professor Papan, he has mentioned this quote a few years ago that we need to think out of the box and do things differently, not as usually. And then we might be able to reach that goal. Thank you very much for your attention.